Okay, so a known cardiac disease patient presents with signs and symptoms of diabetic ketoacidosis, and the resident here was confused on how to approach the case because the main therapeutic modality in diabetic ketoacidosis remains administration of large amount of fluids along with electrolyte correction along with insulin therapy. Whereas in cardiac patient, we have to be very cautious with our fluid administration, and because of the risk of development of signs of volume overload. So how are we going to approach the case? The question is whether we are going to give fluids or not. So the answer is yes, we will be giving fluids, but in a very cautious and titrated manner of, let's say, 250 to 500 ml of fluid aliquots over 20 to 30 minutes. And each time we are going to give fluids to the patient, we are going to assess for the response of the patient to the fluid in the form of IVC, in the form of 2D echo, or let's say we have to look for the signs of fluid overload in the form of development of pulmonary edema. So, and since rest of the management more or less remains the same, that is about the potassium, about the electrolytes, insulin bolus we have to avoid in a new onset MI, and so we can directly start the infusion of the insulin along with RBS monitoring every 1 hour for the initial hours of DKA management, and maybe we can shift the patient to the ICU for a better care and better management of the condition. And but we have to be very cautious in such kind of patients with the fluids, with the electrolytes, and with the finding out the cause of the decay.